Thanks, Dr. James. That's a wonderful introduction. Thank you. I'm very pleased to be able to speak to you today about hydroxyurea and pregnancy. One of the reasons I think that this topic is so important is because we are going to see the increasing use of hydroxyurea globally. And as we have improved the ability of women to reach actually reproductive age with sickle cell disease, we're going to be faced with a challenge of how to manage hydroxyurea therapy around reproductive issues. My disclosures are that I have been on the advisory board for Pfizer and Grifols. And then the objectives of the talk today will be to describe indications and therapeutic clinical protocols for hydroxyurea and sickle cell disease, describe complications of pregnancy in women with sickle cell disease. Then we'll briefly discuss teratogenic effects of hydroxyurea and issues related to breastfeeding in women receiving hydroxyurea therapy. And then briefly, because so many of us recommend contraception during the use of hydroxyurea in women with sickle cell disease, we'll talk about contraception counseling for women with sickle cell disease and provide recommendations around hormonal contraceptives for women. So let's go to the three pre-test questions. The NIH expert panel report, Evidence-Based Management of Sickle Cell Disease, recommends that 1, hydroxyurea is offered to all patients with sickle cell disease starting at 9 months of age, regardless of genotype. 2, all women with sickle cell disease receiving hydroxyurea have monthly urine pregnancy test. And 3, all women with sickle cell disease receiving hydroxyurea practice contraception. Our second pretest question is: the following contraceptives are recommended initially for women with sickle cell disease and stroke, except 1, progesterone-only oral contraceptives, 2, combined oral contraceptives with low-dose estrogen, and 3, intrauterine devices. And then the last pretest question is: the NIH expert panel report recommends that women with sickle cell disease should 1, stop hydroxyurea 2 weeks before trying to conceive, 2, continue hydroxyurea throughout pregnancy to decrease acute pain and acute chest syndrome episodes, and 3, discontinue hydroxyurea while breastfeeding. One of the reasons that it's, I think, beneficial to be in the room today with the moderators that we have is because really sickle cell disease, at least in the pediatric age group, has really realized a lot of the advances of clinical research over the last several decades. And I think that with the advent of infection prophylaxis, newborn screening, stroke risk screening, and the implementation of transfusion therapy to decrease stroke, that we really have seen improvements in the pediatric age group, such that 93% of children born with sickle cell disease will live to 18 years of age. And this is a Chuck Quinn report that really nicely demonstrates this in the first couple of decades of life. There's also a study that looks at Medicaid data from 5 states on treatment pattern utilization in individuals living with sickle cell disease. And a couple things are clear by looking at this data. This very dense red line is the incidence of sickle cell disease-related complications as you go throughout the lifespan, 5, 10, 15, 20 years of age. What's very impressive is in this period between 18 and 22 years of age, where many individuals with sickle cell disease are transitioning from pediatric focus to adult focused care. you see an incredible uptick in the number of sickle cell disease related complications. Now, when you look at treatment patterns, this blue hashtag bar here really demonstrates the use of transfusion therapy in these 5 states for individuals living with sickle cell disease. And as I've kind of mentioned, transfusion therapy for primary and secondary stroke prevention has really played out, I think, in the pediatric population. So that's probably why we're seeing this in the first couple of decades. But this gray hashtag is actually the number of hydroxyurea prescriptions written for that population over the years. So you see a steady increase, but then a little bit of a leveling off and then a decrease as individuals living with sickle cell disease age. I cannot say enough that standing in this audience, particularly with people who provide care for adults living with sickle cell disease. As a pediatrician, one of the things I think is very clear is that we are very heavily resourced to provide care for children living with sickle cell disease, but we really haven't seen those resources reach those who provide care for adults living with sickle cell disease. So many of the things that I think that this demonstrates is not necessarily a change in the quality of care for adults living with sickle cell disease, but really a decrease in the resources available to this population as they age. The Management of Sickle Cell Disease, the expert panel report, was published in September of 2014. And at this moment, I'd like to give a cheap plug out for the American Society of Hematology, who actually produced 3 companion pieces that are trifolds that you can get on the ASH website that really go through some of the salient points in this document. The George Buchanan is here, and he really did an excellent job at getting this group together to look at evidence in the literature to support the management of individuals living with sickle cell disease. And he really tried to get the group together to divide it out into several topics. And one of the topics in the ASH guideline is hydroxyurea and transfusions, and that trifold. You can actually get that off the website, and it's very handy. The other thing that was very impressive about this expert panel report is they looked at the evidence and then they graded it according to the strength of the evidence and then the strength of the recommendations. And although a lot of the recommendations provided were evidence-based, they had to also go to consensus-based in order to get recommendations out in all areas, because there's so many things that there are knowledge gaps in, and we really need good research to fill in those knowledge gaps. But again, remember that this expert panel report was geared to provide this information to primary care providers so that they could also play a role in providing care for individuals living with sickle cell disease. It's not meant to be prescriptive, but just as a guideline and a good way to develop within an individual's institution your own clinical pathways and protocols. Amazingly, 20 years ago, as of May, the MESH study was published and really demonstrated in this randomized controlled trial that hydroxyurea decreased the frequency of acute pain episodes, acute chest syndrome, and the need for transfusions in adults living with sickle cell disease. It took until 2013 to get the Baby Hug trial published, but that study also demonstrated a decrease in pain frequency and acute chest syndrome in children with sickle cell disease who were enrolled on the study between 9 and 18 months of age. So the expert panel report really goes a little bit further beyond what we really gleaned from the MESH study. And recommendations 2 and 4 are pretty intuitive, having played a role, hydroxyurea having played a role in the last 2 decades in individuals living with sickle cell disease and their management. And the second recommendation is adults with sickle cell disease who who have 3 or more sickle cell associated moderate to severe pain episodes in a 12-month period to treat with hydroxyurea. That's strong recommendation, high quality evidence. And then number 4, in adults with sickle cell anemia who have a history of severe or recurrent acute chest, treat with hydroxyurea. The same, strong recommendation, moderate quality evidence. But they were brave enough also to go through and really give us guidance on what we should be doing with this patient population. And the first one is to educate all patients with sickle cell disease, or SS type, or sickle cell anemia, and their family members about hydroxyurea therapy. And then in adults with sickle cell anemia who have sickle cell associated pain that interferes with daily activities and quality of life, treat with hydroxyurea. Strong recommendation, moderate quality evidence. Also in that adult population, if they have severe symptomatic anemia, the recommendation is to treat with hydroxyurea therapy. And then based on a lot of the Baby Hug, Baby Kids work, in infants 9 months of age and older, children and adolescents with sickle cell disease SS type offer treatment with hydroxyurea regardless of clinical severity to reduce sickle cell disease-related complications, pain, dactylitis, acute chest, and anemia. So this really changes the stage for how many of us will be using hydroxyurea therapy, as it broadens the group that really should be receiving hydroxyurea therapy. If you think about it, as this younger group ages, most of them, if they're not on transfusion therapy for primary or secondary stroke prevention, will probably be receiving hydroxyurea therapy. So there's a nice study by Brandow who actually primarily looked at pediatricians participating in the American Society of Pediatric Hematology Oncology to see what provider barriers were related to hydroxyurea use. Because one of the things that has been evident over the last couple of decades is many of the individuals who should be receiving hydroxyurea therapy are not receiving hydroxyurea. Is that patient-based? Is that provider-based? Is that system-based? So I'm just going to look at some of the provider barriers now to really emphasize this concern that hydroxyurea may actually be a teratogen and may be associated with congenital abnormalities in women who receive hydroxyurea while pregnant. And so the provider-related barriers to hydroxyurea group use in this group were the lack of contraception in females, so concern that the women who would be taking the hydroxyurea would not practice contraception. And then the concern for male infertility. And I'm just going to really emphasize this issue around hydroxyurea being a teratogen, and then the concern that women on hydroxyurea wouldn't be practicing contraception. So there is a national toxicology program monograph that came out after the MESH study, because there was a concern that there were going to be more individuals living with sickle cell disease who were going to be receiving hydroxyurea therapy. And they wanted to ask the question, so what is the evidence of hydroxyurea being a teratogen, since there was going to be an increased use of hydroxyurea in this population? And they really were concerned about 2 different issues. One, the issue of a possibility of a decrease in sperm production and abnormal sperm features in males with sickle cell disease receiving hydroxyurea. And a second concern that pregnant women who were exposed to hydroxyurea may have children who have birth defects, abnormalities of fetal growth, or an abnormal postnatal development in offspring. And most of this was based on animal data, and I just want to go through some of this. So why is this a concern? Well, hydroxyurea is an antimetabolite. It's an S-phase agent that inhibits DNA synthesis through ribonucleotide reductase enzyme inhibition, and that you see common toxicities that really impact rapidly dividing cells. Some individuals have darkening of the fingernails. We know that there are hematologic toxicities that can result in neutropenia, reticulocytopenia, thrombocytopenia in individuals who are receiving hydroxyurea therapy. And then on the other side, when you think about germ cell production, we know that there are rapidly dividing cells, particularly in males throughout their life cycle for sperm development, but maybe not as many in oocyte development in women. So we really have not seen a concern for female fertility in those receiving hydroxyurea therapy, but the focus is more on the fetus. So is hydroxyurea a human teratogen, and what are the outcomes of fetuses exposed to hydroxyurea in utero? There are many animal models that have demonstrated that hydroxyurea at similar or higher doses to that seen in use for doses recommended for use in those with sickle cell disease, that birth defects can occur. There are a reduced number of live births, and there's abnormalities of fetal growth. And those abnormalities of fetal growth are related to head and neck problems, cleft lip, cleft palate, neural tube defects, and some extremity abnormalities, polydactyly, syndactyly. However, I will say that it's very hard to tease out in this animal literature that really the doses of individuals who are receiving hydroxyurea with sickle cell disease are similar to those that the animals were exposed to. Some of them were taking as high as 1,000 milligrams per kilogram of hydroxyurea a day. So I think that this is really, really difficult to glean out useful information in this body of literature. And the literature is very dated, and there are a very small number of animals used in these reports. However, there are case series describing offspring of women who have been exposed to hydroxyurea during pregnancy. And I just want to briefly mention a couple of those. Sam Sharash published the first series, and this was something that was a follow-up from the MESH study, where there were 3 women who were exposed to hydroxyurea during pregnancy. And all of these exposures were in the first trimester of pregnancy. 2 of those women on the study elected to terminate, and 1 had a normal child. And you can see that over the years, 99, 90, and 2001, that there were other follow-up studies in women who had received hydroxyurea during their pregnancy, and they all had normal children. However, I think that this is an opportunity to get information from registries. It is tragic that we have so many women who are exposed to hydroxyurea who probably get pregnant on hydroxyurea, but we don't have the ability to get any information from those women where we can make really good decisions. And I think that a registry for women with sickle cell disease who are receiving hydroxyurea, or all those with sickle cell disease on hydroxyurea, is warranted. And I think that Russell Ware is trying to get efforts together to develop just that kind of registries through our organization. So I think that this will be something that we will have to pay close attention to going forward. The other thing that I want to point out is that there are also many reports of women who have been exposed to hydroxyurea through prescriptions that are being used for myeloproliferative disorders. And there are many, many more reports of exposure to fetuses in this group. And this is a article that discusses 23 pregnancies and 22 women. And even though there were a couple of instances where spontaneous or voluntary or medical abortion was used, we do have some live births. There were 16 live births. The 2 intrauteral fetal deaths were after exposure to the first trimester, and there was evidence of placental ischemia in both of those cases, and it wasn't clear whether or not it was as a result of some of the complications of their primary bone marrow disorder, or whether or not it was actually related to hydroxyurea use, as one had not received a prescription for hydroxyurea for 3 months prior. But in the live births, there were a couple of instances here, 3 live births, where there were minor malformations, one pilonidal cyst, one unilateral renal dilatation, and one hip dysplasia. But really, overwhelmingly, very good fetal outcomes in these women who were exposed to hydroxyurea when taken for bone marrow clonal disease. So the next question is, should women with sickle cell disease on hydroxyurea breastfeed? I don't have any information in the sickle cell population. There is one report in the literature in a woman who was receiving hydroxyurea at 1,500 milligrams per day. And that one individual had breast milk sampled. And there were estimates of 3 to 4 milligrams per day of hydroxyurea excretion that could have been associated with exposure to the nursing infant. So if you think about the average weight, maybe of 2 kilograms of a newborn, this really translates into a very, very, very low exposure dose of hydroxyurea to nursing infants. However, there's only this one case, and this is the case that was used by the NTP to base the recommendation on not having women who were taking hydroxyurea breastfeed and avoid exposing their infants. So what are the current recommendations, and how do these concerns around teratogenicity of hydroxyurea impact what we do? Well, there's one recommendation when you're starting individuals with sickle cell disease on hydroxyurea. It is recommended that you get a screening pregnancy test for women at the time that you're initiating hydroxyurea therapy. There are really no clear recommendations on how to monitor pregnancy or risk of pregnancy while women are on hydroxyurea therapy. In talking to colleagues, I've heard things as conservative as monthly urine pregnancy test, or just documenting that the woman is trying not to become pregnant in medical records. And I really think that there's really no guidance in the literature on really what the correct answer is here. But really the only recommendation that the expert panel report made was a pregnancy test for women as they initiate therapy. The other recommendations are that women who are pregnant or breastfeeding should discontinue hydroxyurea therapy. Moderate recommendation, but pointed out based on very low quality evidence. And this is really a knowledge gap here that we need more research to address this issue. And then lastly, the recommendation is that both males and females of reproductive age should be counseled regarding the need for contraception while taking hydroxyurea therapy. And then again, that was an earlier NIH document that also reiterated that when taking hydroxyurea during pregnancy, it could increase the risk of miscarriage, birth defects, restricted fetal growth, or postnatal development. And so then that sexually active couples should avoid becoming pregnant while using hydroxyurea. So I think that we also need to pause and look at the other end of the spectrum, and that's what are the complications associated with pregnancy in women with sickle cell disease. And there have been a number of nice meta-analyses and case series published in the literature over the last couple of years. Kathy Hassel had one a while ago that really was the one and the forerunner that was what we used to base recommendations on, that really looked at some of the literature in the 80s and the early 90s. And then recently, there have been some meta-analyses that have tried to capture some of the more recent case series, not only coming out of the US, but Brazil, the UK, France. There's quite a few case series and large cohort studies on women with sickle cell disease and pregnancy. And there are complications that can impact the woman, and they can be pregnancy-related complications, sickle cell-related complications, and complications that can impact the fetus. And if you look on the right side of this, these are some of the things that are not uncommon complications in pregnancy in general. You can see that these two studies, one out of Duke and one single institution study out of Grady, the one out of Duke actually looked at 18,000 pregnancies in a nationwide database. And the one out of Grady was really a single institution study, but over 300 women were involved in that study. So you see that there are increased antepartum hospitalizations, preterm labor, preeclampsia, pyelonephritis, postpartum infections. And then in the infant, prematurity, low birth weight, IUGR, intrauterine fetal death, and perinatal mortality. And then the sickle cell related complications during pregnancy are an increase in acute pain episodes, acute chest syndrome, but also another complication that can be seen in individuals with sickle cell disease, which is thrombosis, really comes out in pregnant women. And this is a study by Maggie Ragney and her group out of Pittsburgh that looked at venous thromboembolism complications. And you can see that there really are more sinovenous thromboses in pregnant women with sickle cell disease and DVTs. And there's a tendency towards statistical significance for those with pulmonary embolism. So this is something that is a subset that really needs to be addressed in pregnancy or thrombotic complications. What is the evidence in looking between SS and SC? Is it that women with SS have more complications than those with SC? And this study actually nicely outlines that the complications of pregnancy are increased in both SS and SC, but more so in women with SS. And then this slide really is a wonderful study out of the French group looking at mortality in their population. And this study emphasizes, I think, the significance of maternal mortality. And in this study in France, they reported that there were 450 maternal deaths out of 100,000 live births, compared to 9 in those women without sickle cell disease. And so the meta-analyses that we've seen in the literature reporting an odds ratio of 23 for maternal mortality in women with sickle cell disease, we need to think about this and wonder what this is coming from. We definitely recommend to women with sickle cell disease that they should not avoid becoming pregnant if they want to have children. I want to state that because that is something that is very important. But however, we need to emphasize as well that women with sickle cell disease should be considered high risk. And they need very, very close follow-up and care. They need to have serial exams, making sure that the fetus is growing and healthy. We need to pay close attention to pain and acute chest syndrome episodes during this time period. And then we need to have hematologists involved in their care as well, because sometimes we need to work with OBGYNs to co-manage thrombotic complications in women with sickle cell disease during pregnancy. When you look at country data for maternal mortality in Ghana, sickle cell disease represents 5% of that population. In Jamaica, 11%, but in Bahrain, 25%. So this is a global issue, and that we really need to pay more attention to pregnancy and sickle cell and figure out how we can make a difference. So this is some of the data looking at fetal outcomes. We see that there's an increased rate of IUGR, small for gestational age, low birth weight, and there's a tendency to for women living with sickle cell disease who are pregnant to have their deliveries managed by C-section more frequently. So the expert panel report actually recommends the following: the pregnancy in women with sickle cell disease should be considered high risk, and that there is also an increased risk of adverse pregnancy outcomes, including fetal intrauterine growth restriction, preterm delivery, and stillbirth. Additional fetal surveillance is required during pregnancy, and there's increased risk to a woman's health during pregnancy. And these risks should include increased frequency of pain episodes, increased risk for thrombosis, infections, preeclampsia, and death relative to women who do not have sickle cell disease. And then the other caveat to consider is that women with sickle cell disease who are going through pregnancy where they're having increased pain episodes, their fetuses are also being exposed to opioids very frequently. So that there's also a need to monitor for neonatal withdrawal in their newborns when there's use of opioids. So what does the expert panel report tell us about recommendations for contraception in women with sickle cell disease, especially when you're trying to do this in lieu of also trying to maintain on hydroxyurea therapy? Well, we know that women with sickle cell disease experience unintended pregnancies, probably not more significantly than those in the general population. We do know that studies of progestin-only compounds in women with sickle cell disease have not demonstrated an increase in venous thromboembolism. And we can also see that there are some reports that suggest that exposure to progestin might also decrease acute pain episodes in women with sickle cell disease. And then finally, that when even those studies of women with sickle cell disease who are taking combined hormonal contraceptive agents are few, that the ones that we see, there's really a small number that experience VTEs. There are concerns of women who have permanent venous access catheters and the risk for developing thrombotic complications when on combined hormonal contraceptions. And of course, if there's a history of stroke, then it's recommended that estrogen, even low dose, be avoided if possible in these circumstances. So those are really the three clinical areas where you should avoid probably exposing women to combined hormonal contraception and prefer to use progestin-only compounds. These are just some of the older studies that look at VTE risk in those that are exposed to estrogen. You can see that there is one episode here where there were 2 women reported in this study, but really those were the only 2 that reported VTE that I could find. And then this is the study that actually a series of studies that demonstrate that there's decreased pain in women with sickle cell disease who are exposed to progestin-only compounds. So what does the expert panel report say? It says the progestin-only contraception and barrier methods have no restrictions or concerns for use in women with sickle cell disease. And I will say that Dr. James was the one who headed up this section. In the benefits that we should consider, if the benefits are considered to outweigh the risk, combined hormonal contraception should be used in women with sickle cell disease. Remembering, though, that women that have permanent venous access catheters, who have a history of stroke or a history of VTE, that you should use progestin only. Now, let's see how much we've learned. Going back to the first post-test question, the NIH expert panel report, Evidence-Based Management of Sickle Cell Disease, recommends that 1, hydroxyurea is offered to all patients with sickle cell disease starting at 9 months, regardless of genotype. 2, all women with sickle cell disease receiving hydroxyurea have monthly urine pregnancy tests. And 3, all women with sickle cell disease receiving hydroxyurea practice contraception. All right. So I think that I was able to trick a few of you, and that wasn't really fair. Really, the NIH expert panel report says that, yes, hydroxyurea should be offered to all starting at 9 months of age, but it actually specifies SS in that expert panel report. So that was sneaky. I apologize. The next one. The following contraceptives are recommended initially for women with sickle cell disease and stroke, except 1, progestin-only oral contraceptives, 2, combined oral contraceptives with low-dose estrogen, and 3, intrauterine devices. Very good. All right. So I think that the following are recommended initially for women with sickle cell disease, except the low dose estrogen exposure. Remember, that's the situation where we try to avoid that and use progestin only. And then the last, the NIH expert panel report recommends that women with sickle cell disease should, 1, stop hydroxyurea 2 weeks before trying to become pregnant. 2, continue hydroxyurea throughout pregnancy to decrease acute pain and acute chest syndrome episodes. And 3, discontinue hydroxyurea while breastfeeding. So this is, I was trying to get you all really are great. You all really have thought through a lot of this. And actually there is a report that recommends discontinuing hydroxyurea actually before becoming pregnant. That is definitely one of the things that is recommended in a previous NIH report. We don't have a time period established to it. Actually, in the report, it's actually a couple of months before. So Kathy Hassel, do you remember that the monograph? Yes, there you go. So it doesn't have a time period established with it. So that wasn't really fair. But discontinue hydroxyurea while breastfeeding is definitely there. So what are the conclusions of this talk? Well, women who are taking hydroxyurea should not become pregnant while receiving hydroxyurea. However, I suggest that the morbidity and mortality around pregnancy needs to be addressed in women with sickle cell disease, and that we really need good studies to look at whether or not it is safe to either expose individuals to hydroxyurea at some point during pregnancy, starting with animal models, if we can find them, would be the appropriate place to start there. Women with sickle cell disease who wish to become pregnant who are receiving hydroxyurea should discontinue hydroxyurea, as well as those who are breastfeeding. But again, I challenge with the breastfeeding women that we need to get more data to support these recommendations or to refute them. Women with sickle cell disease who wish to avoid pregnancy should receive contraception counseling that includes options for hormonal contraceptive agents in addition to barrier methods. And then the last one is that research is needed to determine the impact of hydroxyurea on conception, pregnancy complications, pregnancy outcomes, fetal growth and development, neonatal exposure through human breast milk. And really another plug for the use of registries. There are 3 either ongoing or in the works that I think that really will be able to make a significant impact. I think the one that we are sponsoring on hydroxyurea should be considered. Sickle Cell Disease Association of America has one that's up and running called Get Connected. It's really more, when you think of a registry, it's not that classic. It's actually those that are trying to get individuals enrolled in this database so that we can give those living with sickle cell disease good information and to make sure that they have access to good medical care. But hopefully that will be a venue for patient reported outcomes. And then there was a recent RFA through the NIH and HLBI that actually will be supporting a registry for those living with sickle cell disease once that is awarded. So with that, I'll end. Thank you.
Very good. Thank you.